Hi, I'm Joe Moose. I want to talk briefly about the economics of pharmacy and the economics of healthcare that are driving some new models of pharmacy. Today I want to give you a roadmap to a new model of care, a new model of payment. We're not telling you where you have to go, but this map will tell you where you can go. The new models of payment in healthcare are going to force us to rethink pharmacy and rethink the way that we provide value in the healthcare system. Somebody's going to be out there filling prescriptions fast, accurately, and cheap, and there's a role for that. But there's also a role for those of us who want to provide value in a different way, and that's value that's driven on giving the healthcare system the outcomes they need. So in this legacy system, we have someone walks into the pharmacy with a prescription because they were at home and they got sick. They felt bad. They went to the doctor wrote them a prescription. They walked into the pharmacy. They filled the prescription, or maybe they didn't fill the prescription. But let's assume they filled it and they took the medicine, but maybe they didn't take the medicine. So let's assume they did take the medicine and they did get better or they got worse. And that's the end of the story unless they got worse and they ended back up in the hospital or in the emergency department. So that legacy system's not really working. That's going to hashtag fail. Let's sweep that system to the right and delete it completely. Or you have this situation where a care manager is saying, hey, I can't get this patient. They continually have a high hemoglobin A1C. And the claims data person or the insurance company is saying, well, I don't even see a claim for any diabetes drugs. And the pharmacy says, we don't have any diabetes prescriptions on file. And the physician says, for over a year, I've been writing this medication for diabetes. And finally, the conversation with the patient tells us, oh, I took the sample I got and it upset my stomach, so I quit taking it. So we've got 5 different stories that are not tied together anyway. Healthcare models are going to force us to start tying those stories together, to start finding the commonality in all of these stories so we can take this one story and deliver the best value and the best care out there. What's the problem with just leaving it the way it's always been? Pharmacy's always been a great profession. Why do we have to go changing the model now? The economics of it are driving us to. The math is not there. We simply can't afford it anymore. With greater than 54% of the patients having 3 or more chronic conditions, with greater than 73% of the dually eligible patients having hypertension, and greater than 30% of those having some behavioral health disorders, it's gotten so expensive we can't afford to just be pill fillers anymore. We have to be value deliverers. So we have to find out, how do we give the healthcare system what can make a difference, lower that total cost of care, and how can we give the healthcare system better quality of care in a most efficient and economical way. By 2018, the White House plans to shift greater than 50% of their fee-for-service payments for healthcare to a value-driven model of healthcare. We need to capitalize on this as pharmacy. We're in the value business. If you think of all healthcare out there costing $100, for the entire nation, everything spent on healthcare is $100. And you think of that pie, $100 piece of pie, about $5 to $20 of that $100 piece of pie is spent on drugs. And if you've got everybody in your pharmacy, if the pharmacists are working at the top of their degree, doing what you're doing day to day in your pharmacy, and your technicians and all your staff are working at the top of their ability, when we catch drug interactions that are preventing hospitalizations, we're not lowering that $20 piece of pie any, or that $5 piece of pie. We're lowering the $80 piece of pie or the $90 piece of pie that's over there in the healthcare spending, where hospitalization is, where expensive tests are, where physician offices are. So we've got to get paid out of the $80 piece of pie. We've got to be thinking what we do is not just saving the drug budget money. If we're working on adherence, we're probably going to spend more on drugs. If we're working on total cost of care and reducing what the nation's spending for care overall, and we're working at the top of our degree, we're really lowering the $80 piece of pie. And that's where I want you to remember today, and I swear I want you to continue to think on how can I engage, how can I help reduce the $80 piece of pie, and how can I start getting paid from the $80 piece of pie where our value is really shown. The Congressional Budget Office says a 1% increase in adherence leads to a 1/5% decrease in the total medical spend. So a 1% increase in that $5 piece of pie will give us a 1/5% decrease in the $95 piece of pie. We're talking a lot of money. We're talking big dollars then. That's why we need to be paid out of the 95% piece of the pie. The big box guys don't even need to make a margin off drugs anymore. If you're in the PBM business, or if you're in the selling tires and selling sports equipment and selling TVs, you don't need margins off of drugs. As healthcare providers, we have to really drive home the value that we bring. As healthcare providers, we have to also be part of the team, an integral part of the team. We have to be able to share our information with someone other than the patient. We have to share it with everybody in the healthcare spectrum. And we have to also be able to consume information and data that other healthcare providers have, so we can give one uniform, one gap-free delivery of care. Community pharmacy is excellently positioned to be a healthcare provider. We've been talking the talk for years. Now it's time we deliver on it. We're positioned great for this. We're nimble. We're early adopters. We have an unlimited tool set. We have unlimited resources around it. We've got community involvement and community connections, and we have a direct incentive to perform, which we can do. Just like one lick on a guitar doesn't make a song, or one guitarist doesn't make a band, pharmacy operating in a silo all by itself doesn't make a healthcare team. What we need is collaboration. We have to learn to collaborate with other entities. I think that's the word for healthcare in the next few years in the future, is how can we collaborate? So what is collaboration? The act of working with someone to produce or create something. About 8 years ago, I made a discovery. And this discovery profoundly affected the way I view healthcare. And what I'd noticed was there's a pattern. And in this pattern, it seemed like the most complex patients that were the most difficult to deal with, are the ones that needed the most care coordination. So I went from doctor to doctor telling about how we could help with care coordination. I said, give me your most complex, give me your most difficult patient, and we'll put them through our robust adherence program. We'll pair them up with our brilliant PharmDs to go through and do medication reviews and do CMRs, and we'll take care of your patients. We'll get them adherent and we'll fix all their problems. Just send us your most complex patients. So after going around a while telling that from doctor to doctor, we finally got some doctors to buy into it, and they sent us their worst patients. And we put them through our award-winning adherence program, and we synchronized them, and we did special packaging and strip packaging, and our brilliant PharmDs met with them face to face. And what we found out is we couldn't do it. We failed. And the reason we failed is it's not a pharmacy problem, it's a healthcare problem. We had to start connecting all the players of the healthcare team. We couldn't fix it just in pharmacy. We had to connect with the doctors. We had to connect with the nurses. We had to connect with the parish nurses. We had to connect with family members of this patient to make sure that the care was consistent all the way through the healthcare spectrum. And that all the players in the healthcare team were talking and communicating across each level with each other. Because this is not just a pharmacy problem, it's a healthcare team problem. We learned that it might be just as important to connect this clinical community pharmacist with another healthcare provider. That might be just as important as connecting the pharmacist face-to-face with the patient. So what does this medical neighborhood look like that we're asking community pharmacy to start connecting with? It can be physicians, it can be hospitals, discharge planners, transition of care team members. It can be data specialists, it can be payers or insurance companies. It can be anyone who has some activity with the patient, who's trying to drive the outcome of increased quality for that patient at a very affordable cost. So what does community pharmacy bring to the table for the medical neighborhood? We can bring narcotic counseling. We can bring transition of care counseling. transition of care work. We can bring adherence counseling. What we really bring is we bring pharmaceutical care coordination, true pharmacy care coordination. Sometimes the things that are measured are not all clinical parameters. Sometimes it's getting the patient access to care and getting the patient what they need that's going to keep that patient out of the hospital. So pharmacies are working in adherence now. We're being challenged to step up the game on adherence, and we're making money by doing it too. Adherence has been a good thing for pharmacies and a good thing for our patients. It increases our volume. It increases our generic utilization. Our efficiency is increased in it. It can increase traffic into the pharmacy as well as decrease our inventory. So all these factors are, bottom line, are helping our patients. A couple of years ago, I was asked to speak to a group of psychiatrists. I was in this beautiful banquet hall in Pinehurst, North Carolina, golf mecca of the world, and speaking to several hundred psychiatrists. And I was telling them our program about how we had an adherence program and how we would synchronize our patients and how we would do special packaging for our patients. And we really connected with them, and we followed them throughout the month, and we followed them throughout the year on their care. And we communicated back to physicians when there were failures in therapy, and when patients decided not to take things, and we had a real good team effort. And I did my 20-minute presentation and then walked out of the banquet hall, and the next speaker started talking, and I'm walking down the hall of this beautiful golf club, and there are golf clubs on the wall from Tiger Woods on this side, and their famous golf bags and things on the wall, and art. I'm just kind of walking down the hall admiring all this stuff, and I heard somebody say, "Hey, Joe," and I turned around, I had about 8 psychiatrists follow me. Not a very comfortable feeling, but what they wanted to really know was, where's the pharmacy in my neighborhood that does what you were talking about? And this was one of those aha moments for me that let me know this is not just a one pharmacy thing. This is something that pharmacy as a whole has to adopt and embrace. So we have to start looking for these novel type partnerships out there in the community where we can leverage our skill set to help benefit the patient, to help start closing these gaps in care. So after discussing what we could do at our pharmacy out in the hall with these physicians, they were all like, is there a network or something that we can call to find out where all these pharmacies are? So that was that moment that made me think we need to band together as community pharmacy. We need to have a high-performing network where we can leverage our skill set across a broad spectrum so providers know where to go and know where to refer these complex patients to get the certain outcome that they desire and to close these gaps in care. So what would this high-performing community pharmacy network look like? What would be the enhanced services that we provide? Well, our enhanced services are whatever their needs are. We have to have connectivity to the medical home. We have to have connectivity and access to the providers to share information. We also have to know who all is on the team, who are the healthcare team members that we may have access to communicate with and to share with. We also need a population view of the panel of patients that we need to work with. We need some way to find out who are the riskiest patients, who are the patients that we can put our effort in and get the biggest return on investment for our plans. And we also need a good referral system where they can refer the patients to us. So a lot of these novel partnerships may be new and a little difficult for us to start in our practice, but we've got to adopt it, and we've got to adopt this new change. Change doesn't come easily, but community pharmacists is nimble, and we've always been adaptive. I've said before, I think community pharmacists are the Swiss Army knife of healthcare, and I think you can prove it. It's not the strongest of the species that survives, nor the most intelligent, but the one most responsive to change. So the big conundrum for community pharmacy is, how do we maximize our current revenue streams, yet build an infrastructure that can handle the new payment reforms and the new payment models that are coming down the pipeline? So what can your pharmacy do? You can work with the local Medicare subcontractors, working with skilled nursing facilities to reduce readmission. You can work with local self-insured entities to help them manage their complex patients. Or you can work with a payer and help them manage the most complex patients. Tons of opportunities out there to increase your your referral base for these complex patients who need somebody to be a gap stop. So what you're really trying to do is you don't want to just fill prescriptions, you want to fill local needs. So what do these novel partnerships look like? It may be helping a hospital reduce their 30-day readmission rate. You can look up their 30-day readmission rates and refer back to that and see what kind of rates they have with certain disease states. And maybe you're helping them reduce their readmission rates with MIs, or maybe you're helping them reduce those rates with their CHF patients or pneumonia patients. This is important to hospitals. Patients who receive MTM services from a community pharmacy are 3 times less likely to have a readmission in the next 60 days. This is valuable to payers. We really need to leverage the skills of community pharmacy to drive these outcomes. Adherence is important, and we really need to find which patients need to be adherent to what drug. The most expensive patient to the healthcare system is not the patient taking 14 or 15 medications, but it's the patient with a chronic disease that's not taking any medication. So we need to identify those patients that aren't taking medications that need to be on chronic therapy. There's so much new technology out there that can help pharmacy and help pharmacists identify gaps in adherence that we need to be leveraging this technology to help us out. If you haven't seen Justin Wilson's course on technology, you've got to see it. He dives in deep on all the technology available to the market today to help you with this. It's more than you can handle as an individual. With the number of disease states increasing and the number of drugs increasing every day, we've got our hands full with keeping everything straight. Monitoring adherence manually is just antiquated in our system and will never catch up. We have to leverage that technology, and Justin will tell you how. Working with the patient to keep them more adherent also builds trust with that patient, and it builds that stickiness where that patient is now connected to you as one of their healthcare providers. They don't go to Pharmacy X, they go see Pharmacist Smith or Pharmacist Joe, and that builds a strong bond. When we're talking about adherence counseling, we're talking about getting the patient to opt into their own health care and opt into their own regimens. We developed a report card to show physicians how good their patients were doing with their adherence. And we would print this out with all our complex patients and then give that to the physician and say, hey, we've moved them from this measure to the next measure in adherence. And one day we left that report card attached to the bag and the patient accidentally saw it. And the patient asked me, he said, what is this? And I said, oh, that's a way we have to track how well you're doing with taking your medicine. And the patient told me, he said, wow, if that's important enough for you to measure, then maybe I need to be doing a better job about taking care of it myself. And that was kind of another aha moment for me, is that, you know, in all this technology out there, we had kind of left out a very important link. We had left the patient out of it and left the patient's voice out of it in their own care. So we always want to look at what are the patient's aspirations with their disease when we're trying to work towards making them more adherent to their regimen. The number one question I get asked at conferences, where do I start? We've been a great pharmacy at filling prescriptions fast, accurately, and cheap, but where do I start changing my model? Probably the number one starting place you can have is providing physicians with an accurate med list. They have their med list of what they've prescribed. You have the med list of what the patient is actually getting. You interview the patient voice and you get what are they really taking and provide that med list to physicians. Adherence is another great place to start, especially with these most complex patients who have a lot of gaps in their care. So there's certain disease states out there that you may specialize in. I don't think you have to change your pharmacy completely on day one to an all-clinical model. I think you find something that you're good at and you focus on that, build that up, and then start adding pieces to that as you go along. One of the first avenues we went down was we had a patient who was really struggling with narcotics and narcotic abuse. And we sat down with them and did a MTM with the patient and laid it all out for them and said, hey, we're gonna start strip packaging your medication, and this is how many you get, and really helped get it organized, and started coordinating, which was this cascade of multiple doctors down to one doctor. And the patients came to us after doing this for about 3 months and said, you know, I was searching for that for some time, and you've really helped me. You know, I was definitely addicted to this, and not only have you helped me get my life back in order in terms of my health care and get off of these narcotics and start getting my pain under better control, I've decided that I want to be a narcotic counselor, and he's now enrolled in the community college taking classes to be a counselor. And that's just one way to take one isolated event that happened over the counter in a pharmacy and build on that and expand your practice on that one type of event to where you're getting a referral in a specific area and you can focus on that. We've talked about a lot. We've talked about economics. We've talked about healthcare payment systems. We've talked about collaboration. We've talked about many things today. My challenge for you is at the end of this is that over the next year, over the next week, over the next couple of days, I want you to work with finding ways to collaborate with other people in your healthcare team so you can work together to deliver the most efficient and most effective healthcare possible. I'm Joe Moose, and I want to thank you for joining me for this portion of Rethink Pharmacy.